Hey, what's up guys? It's Dr. Suchard again. This time we're going to be discussing salicylates, which for the most part means this is the video about aspirin toxicity, corresponding with Chapter 37 in Goldfrank's Toxicologic Emergencies. The learning objectives are that once you've studied all the related materials, you should be able to describe the symptoms, signs, and laboratory abnormalities seen with salicylate toxicity, identify at least 3 potential sources of salicylate toxicity that can be found around the home, and to outline the treatment options for salicylate toxicity. I'm going to start off with a review of the history of salicylates and aspirin. Some plants have been known since antiquity of having pain-relieving properties, such as the bark of the willow tree, or Salix species, as well as meadowsweet, Spirea species. Plants like these were used for centuries before the active ingredient was isolated in the 1830s. Various salicylates were then used pharmacologically to treat gout and other rheumatic complaints. They actually worked, which was a lot more than can be said of many contemporary medications, but these salicylates developed a reputation for adverse drug effects, especially on the stomach and the heart. In 1897, Felix Hoffmann, who was working for Bayer, a major German drug manufacturer, developed a feasible method for mass production of an acetylated form of salicylate, acetyl salicylic acid, or ASA. It's been reported that Hoffmann wanted to create a salicylate derivative that had less GI toxicity, which is kind of ironic in retrospect given how we look upon it now as having fairly prominent adverse GI effects. The resulting drug was named aspirin, with the letter A standing for acetyl, followed by SPIR from Spirea, the genus name for meadowsweet, and ending with in, which was a common drug name suffix at the time. And it was the blockbuster drug of 1899 when it was commercially released. Oh, and that guy Hoffmann? In 1897, he also developed Bayer's other blockbuster drug of the turn of the last century, heroin. In fact, he developed the methods for manufacturing both drugs in the same 2-week period, although maybe that's not as crazy as it sounds since both methods involve the same mechanism of cooking a known drug with acetic anhydride to acetylate it. Aspirin's popularity was boosted further with the 1918 Spanish flu pandemic at the tail end of World War I. As one of the few actually effective drugs in the pharmacopoeia, aspirin was used freely for the aches, pains, and fever of influenza. In fact, some research suggests aspirin was overused at the time, and it may have been so overused that it contributed to that pandemic's high mortality rate. A contemporary author noted that aspirin was dosed, at least in this one case, by the half handful. In retrospect, it could easily be that people presumed to have died from a viral pneumonitis could have died from what we would now identify as expected complications of severe salicylate toxicity. But more than a century ago, those two conditions would have been clinically indistinguishable. Aspirin, and particularly Bayer aspirin, the flagship brand, continued to sell remarkably well. And one of aspirin's continued selling points was that it does not affect the heart. The potential beneficial effect on cardiac health to reduce the risk of occlusion myocardial infarction was not recognized until the 1970s. Aspirin remained hugely popular for decades and was found in basically every home that had anything at all in its medicine cabinet. In the upper left, we see a small tin that someone could carry in their pocket or purse, with the tablets each containing 5 grains, an essentially obsolete apothecary weight measure, of aspirin. This is just a skosh under the 325 milligrams we currently see in regular aspirin tablets. Children's aspirin was also marketed and wildly popular. Why so popular, you might ask? Well, it didn't have to compete with acetaminophen or over-the-counter NSAIDs because they weren't available yet. Each children's aspirin had 1/4 the adult dose unit, at 1¼ grains or 81 milligrams, which is still a standard dose used most typically today for daily cardiovascular protection in adults. I remember well these small, chewable, and quite tasty children's aspirin tablets I was given in the early 1970s. This appeal and palatability was part of the danger, though, in that kids could think of them as candy. The particular bottle shown here actually has some child-resistant packaging, but children's aspirin was around long before that was common. A landmark paper about salicylate toxicity was published in Pediatrics in 1960. Dr. Alan Doe noted that salicylates were the most commonly ingested toxic substances by children, with aspirin accounting for over 1/4 of all pediatric toxic ingestions and more than half of all pediatric drug ingestions. And even in adults and adolescents, salicylates were the second highest rank among suicidal ingestions. So, in 1960, salicylate toxicity was basically bad guy number 1 in terms of poisoning risk. But several things have occurred since then, reducing the risk and occurrence of salicylate toxicity, such as safer child-resistant packaging, the recognition of Reye's syndrome's association with aspirin exposure, and the nearly contemporaneous availability of alternate over-the-counter antipyretics and analgesics such as acetaminophen and ibuprofen. And while aspirin is still the primary source of toxic salicylate exposures, salicylate toxicity can occur from non-aspirin products too. The active ingredient of Pepto-Bismol is bismuth subsalicylate. Each 1 fluid ounce dose of Pepto-Bismol contains 261 milligrams of salicylate, such that chronic use, especially in the presence of some renal insufficiency, can lead to salicylate toxicity. Many muscle rub creams like Bengay contain a substantial amount of methyl salicylate, which is metabolized by demethylation into salicylate. When used topically as directed on intact skin, the amount of salicylate absorbed is negligible, but if repeatedly applied to inflamed skin, or if used improperly, like when it's ingested, say by a curious child, the salicylate exposure can be toxic. Oil of wintergreen contains even more methyl salicylate, nearly 100%, such that each teaspoon has as much salicylate as 22 aspirin tablets. And it has a pleasant minty smell, which has led to unintentional ingestions and toxicity. Concentrated methyl salicylate is also a component of various muscle liniments, probably because, if it smells strong, it must be strong. Many consumers have mistaken the intended use and ingested these products instead of applying them topically. And there are also wart and corn removers like Duofilm that contain high amounts of salicylic acid and lactic acid that need to be stored safely to prevent accidental household exposures. Getting back now to aspirin, we know that aspirin works by inhibiting synthesis of various prostaglandins, and that this can result in a range of potential adverse effects, affecting the GI tract, the kidneys, and blood clotting/platelet adhesion. But that's all we're going to say about therapeutic dosing. But we're interested now in toxic effects, and the concept of toxicity may be taken to imply those adverse effects occurring due to elevated drug levels. Salicylate toxicity is classically characterized as producing a mixed acid-base disorder, including a metabolic acidosis, which is practically the same as saying that the serum bicarbonate level will be abnormally low. Toxic salicylate levels interfere with the citric acid cycle, uncouple oxidative phosphorylation, and increase fatty acid metabolism. The bicarbonate is low because there's an accumulation of other small organic acids that take its place. These acids include pyruvate, lactate, the ketone bodies beta-hydroxybutyrate and acetoacetate, and the salicylate itself can account for a few milliequivalents per liter. Since the bicarbonate is lowered, while chloride is not affected, this will increase the serum anion gap. And I show here another graphic with the mud piles mnemonic for an elevated anion gap metabolic acidosis, where the letter S stands for salicylates. So the mixed acid-base disorder consists of a metabolic acidosis and also a respiratory alkalosis. And this is not simply a compensatory reaction to the acidosis, but it's a primary respiratory alkalosis because salicylate stimulates respiratory drive in the brainstem, resulting in a degree of hyperventilation that drives down the PCO2. In a patient with serious salicylate toxicity, we can see changes in the pH and acid-base status over time. Early after the overdose, the first thing seen will be the respiratory alkalosis, and the patient's pH will be elevated. They will be alkalemic. Then, the metabolic acidosis develops while the respiratory alkalosis remains. In this phase, the pH will start to decrease, and at some point, the increase in pH from respiratory alkalosis will be exactly countered by the decrease from metabolic acidosis, so a normal pH does not rule out significant salicylate toxicity. Later in the course of very serious poisonings, the patient may tire out or have CNS depression, resulting now in respiratory acidosis, hypoventilation, and the pH will start to plummet since both the respiratory and metabolic acid-base disorders are going in the same bad direction. Metabolic effects of salicylate toxicity include both the potential for hyper or hypoglycemia. Glucose might be elevated due to the acute stress of the poisoning, increasing the levels of various counter-regulatory hormones, or due to increased energy demands in the face of impaired ATP production from TCA cycle inhibition, hypoglycemia can be seen. Salicylate can also uncouple oxidative phosphorylation in the mitochondria, impairing the efficiency of ATP production and releasing energy as heat, resulting in hyperthermia. So that's a bit ironic in that a drug commonly used to reduce fever can instead, in overdose, raise the body temperature. With regard to GI effects from acute toxicity, nausea and vomiting are common, contributing toward fluid depletion. A whole range of altered mental status can occur, ranging from confusion and agitation to seizures or coma. Part of these CNS effects may be due to the CSF glucose levels being lower than in the serum, a state called hypoglycemia. Salicylate toxicity may also cause ARDS, adult respiratory distress syndrome, a non-cardiogenic pulmonary edema. And if you combine this with the hyperthermia from uncoupling oxidative phosphorylation, we see how this can easily be mistaken for infectious pneumonia. Salicylate toxicity is also frequently associated with tinnitus. Tinnitus is derived from the Latin word tinere, to make a ringing sound like a bell, but patients don't always describe it as a ringing. Often it's described as a rushing or roaring sound, or sometimes just a decrease in auditory acuity. But I want to get back for a moment to the acid-base issues. Acid-base status is critical with salicylate poison patients because anything lowering the pH is going to make them worse. Salicylate is a weak acid with a pKa of 2.9. It may exist either as the salicylate ion or the uncharged salicylic acid. At a normal physiologic pH of 7.4, much higher than the pKa of salicylate, the great majority of the drug is in the charged salicylate ion form, whereas only a small portion exists as uncharged salicylic acid. The salicylate ion is more water-soluble, so it tends to stay dissolved in the blood, and it's filtered in the kidneys and can be more easily eliminated in the urine. But anything lowering the pH will increase the relative amount of salicylic acid, which is more easily able to cross membranes and become absorbed into the body tissues, including into the CNS, which is the pathway leading to a bad outcome. So this will help guide therapy because we want to correct the acidosis and to avoid anything that might lower the pH. Probably the most testable point about salicylate toxicity, if there's going to be only one question about aspirin on an exam, it's going to be this one, about the toxidrome of salicylism. If a clinical scenario describes a patient with respiratory alkalosis, a metabolic acidosis, and tinnitus, it's going to be an aspirin overdose case. From the clinical perspective, if you didn't have a history of aspirin overdose, salicylate toxic patients can be hard to diagnose, because it pretty well mimics some other more common diseases. It can mimic meningitis, or rather meningoencephalitis, because there's altered mental status. It can mimic pneumonia, as we've already discussed, due to adult respiratory distress syndrome. And if you saw a patient with an elevated lactate and an increased anion gap, you'd be right more often than not thinking that it's sepsis, so you have to be pretty free in obtaining serum salicylate levels to avoid missing the diagnosis. Fortunately, getting salicylate levels is pretty easy as long as you think about it. It's available as a stat test result in virtually every acute care setting. And we can use the results to help guide therapeutic interventions, i.e., who needs to be treated and with what measures. For reference, we start to see aspirin's analgesic effect at salicylate levels of 5 to 10 milligrams per deciliter. When used as an anti-inflammatory drug, say for various rheumatologic indications, the levels should be in the 10 to 30 milligrams per deciliter range. Tinnitus is seen beginning at the upper end of the therapeutic range, but any salicylate level above 30 milligrams per deciliter indicates overuse or a possible overdose, and it's a reasonable threshold for starting treatment. Further down, we see that extracorporeal removal, hemodialysis, may be indicated for very high salicylate levels, and also that there's a difference between acute and chronic toxicity. If there's been ongoing overuse of salicylates, the total body stores are higher for any given serum level, so we might consider hemodialysis for chronic toxicity maybe at a level of 50 to 60 milligrams per deciliter. But with an acute aspirin overdose, there hasn't been time yet for the salicylate to be absorbed from the systemic circulation into body tissues, and that's a great time to remove it by hemodialysis, which is indicated for any patient with a salicylate level of 100 milligrams per deciliter. One thing to take note of here are the units of milligrams per deciliter. This is the most common way salicylate levels are reported, but it's not the only way. Some labs report milligrams per liter. I was consulted once for a patient that the physician thought might need dialysis, and they said the patient's salicylate level was 110. I asked how the patient looked, and the doctor said they looked okay. I asked about the vital signs, and they were normal. I asked about the anion gap, and it wasn't elevated. And when I asked about what units their lab reported, this was in milligrams per liter. So I was able to explain that the patient had, if anything, a therapeutic salicylate level of 11 milligrams per deciliter and didn't need treatment for aspirin toxicity. With acetaminophen, we have the Rumack-Matthew nomogram, and for salicylates, there's the Doan nomogram. However, the Doan nomogram is limited to categorizing the expected degree of clinical toxicity. In his 1960 paper, Doan described patients as having mild, moderate, or severe salicylate toxicity, or being asymptomatic, and was able to generate this graphic. But this doesn't tell you when to treat or who to treat, although you might intuit that people with more than mild toxicity probably should get directed treatment. You can graph a point for your patient and say whether you think they fit the expected degree of toxicity or not. But you can make treatment decisions based upon how sick your patient looks now, what their salicylate level is, and other lab values like the pH and the anion gap. Where nomograms are really useful is when a patient might later become sick, even if they look okay now, and we'd like a drug level to help determine if we need to start treating this currently asymptomatic or minimally symptomatic patient. So the Doan nomogram is interesting, but we don't use it to make treatment decisions. If we are going to treat salicylate toxic patients, how do we do this? Treatment for salicylate toxicity consists of symptomatic and supportive care. Well, that really applies to every patient. But some portions to pay particular attention to here include the fluid status and IV hydration needs. Sick adult aspirin overdose patients can be 4 to 6 liters dry at the time of presentation to the hospital. They've had all kinds of fluid loss from vomiting, breathing fast, sweating, hyperthermia, and the primary route of salicylate elimination in overdose is renal, so ensuring adequate hydration to produce plenty of urine is indicated. We will be monitoring several lab results, including glucose levels. Remember that either hyper or hypoglycemia may occur, and even if the serum glucose is normal, it's possible to have low glucose in the CNS. So as long as the patient isn't hyperglycemic, supplement glucose freely. And we'll be getting serial repeat labs to see if the salicylate levels are going up or are going down, and other labs to monitor the acid-base status. The next step is alkalinization with sodium bicarbonate. IV bicarb helps to treat acidosis, which helps to reduce absorption of salicylate from the blood into the tissues. And we are also giving the bicarb, which is eliminated in the urine, to raise the urine pH, to ion trap the salicylate in the urine, preventing its reabsorption. I like to consider systemic alkalinization with IV bicarb as a metabolically invasive treatment, in that you're going to have to closely monitor the levels of several electrolytes, likely needing to provide potassium supplementation too at some point, and paying close attention to the patient's fluid status. And you also have to consider whether hemodialysis is indicated for the sicker patients. Published recommendations say that any patient with a salicylate level of 100 milligrams per deciliter is a candidate for dialysis, but it might also be indicated at lower thresholds for those with chronic salicylate toxicity, altered mental status, or persistent acidemia, those with renal insufficiency since they can't eliminate salicylate in the urine, who can't tolerate aggressive fluids, or patients with lower salicylate levels who are getting worse despite appropriate and aggressive fluid and alkalinization therapy. These are the times to consult nephrology regardless of the hour. Just a couple more points about pH and acid-base status. The graph on the left shows how much more efficiently salicylate is eliminated with the urine as the urinary pH goes up. So you'd also like to serially monitor the urine pH to see how well alkalinization therapy is working. On the right side is my warning about sedation and endotracheal intubation. Now, some patients may need sedation or intubation, and you have to do it, but with caution. In a very sick patient, the only thing preventing them from being even more acidemic is their respiratory alkalosis blowing off CO2. The patient's brainstem centers are probably smarter than you are, keeping the patient breathing fast and deep, and if you sedate them too much, their pH can drop. Also, if the patient needs to be intubated, and they're typically given a neuromuscular paralytic to do this, they're going to be apneic for a short time period, which can also cause the pH to drop precipitously, so the potential for peri-intubation complications is concerning. And after intubation, the ventilator settings can't be set to normal values. The hyperventilation needs to be maintained. Some poisons have reversal agents or some more or less specific antidotes, but aspirin doesn't. The closest thing to an antidote for salicylate toxicity is sodium bicarbonate for systemic alkalinization and urinary alkalinization to affect the pharmacokinetics of salicylate, disfavoring tissue absorption and favoring urinary clearance, rather than affecting its pharmacodynamics. There's going to be a lot more about how to administer sodium bicarbonate in a separate antidote-specific video. And with that, we're done with this video about salicylate toxicity. I'll be seeing you around.